All right, welcome. We'll begin the consultant level viva. The subject is general surgery. You're the candidate. You have 10 minutes on the clock. Let's begin.
Here's your case. You have a 39-year-old man in the emergency department. He's got a painful swelling in his right lower abdomen, and it's been there for about a day. So talk me through it. How are you going to approach this patient?
Thank you. My approach is going to be systematic. I'll start by taking a focused history and doing a physical exam to really nail down a differential diagnosis. From there, I'll lay out a clear management plan. That'll cover the consent process, the details of the operation itself, and, of course, a good discussion of any potential complications.
Okay, a solid framework. Let's start right at the beginning then. The history. What do you need to know?
Well, first, I'm honing in on the presenting complaint. The timeline. When exactly did this swelling start? Then, I'm immediately looking for red flags. Signs of strangulation. Is the pain getting worse? Is he nauseous? Is he vomiting? Is he completely constipated? Because that screams bowel obstruction. A really critical question is about reducibility. Could he push it back in before? Can he now? That tells me a lot. And finally, I touch on constitutional symptoms like weight loss, just to make sure I'm not missing something bigger picture.
Next, I dig into his risk factors. I'm thinking about anything that increases intra-abdominal pressure. So does he have a chronic cough, maybe from COPD? Does he strain on the toilet from constipation? What about his job? Is he lifting heavy things all day? It's also super important to ask about any previous abdominal surgeries, because this could easily be an incisional hernia. And of course, I'll ask if he or anyone in his family has a history of hernias.
All right, moving on to the physical exam. My focus is squarely on his abdomen and groin. After making sure he's properly exposed and has a chaperone, I'll start with inspection, looking for any obvious masses or changes to the skin. I'll get him to cough, to see if there's an expansile impulse. Then, on palpation, I'm going to carefully feel the swelling. I need to know exactly where it is in relation to the inguinal ligament, what its consistency is, and probably most important of all, can I reduce it?
Okay, good. You've gathered your initial data. So based on this kind of presentation, what's your top differential diagnosis? And what's your immediate plan of action?
Given that this is an acute, painful, and likely irreducible swelling, my number one diagnosis is a strangulated inguinal hernia. But a very close second, and a critical one not to miss, is a femoral hernia, since the risk of strangulation is so high. I differentiate that by its position below the inguinal ligament. Obviously, I'd keep other things in mind, like a hydrocele or even inguinal lymphadenopathy, but they're much less likely to present like this.
My immediate plan is to treat this as a surgical emergency. No messing around. So I'm admitting him, making him nil by mouth, and getting IV access right away for fluids. I'll send off for baseline bloods, including a group and save. The definitive treatment here is an urgent trip to the operating room for surgical exploration and repair. So I will start the consent process and get him on the list.
And really, the absolute cornerstone of this whole prep phase is getting a proper informed consent. Even though it's an emergency, it is absolutely vital that we have a thorough chat about what we're planning to do, what the alternatives are, and what could potentially go wrong.
During that consent discussion, I'd explain that he needs an open repair of his right inguinal hernia and that we'll most likely use a prosthetic mesh. I'd also mention that while laparoscopic surgery is an option for elective cases, in an emergency like this, the open approach is just safer. And then the most important part, the risks. I'll talk about bleeding, infection, the hernia coming back, and specifically for this surgery, the risk of chronic pain from nerve injury and the potential for damage to the spermatic cord structures, which could even affect the testicle.
Very good. Okay, you're in the operating room. Talk me through the key steps of an open, tension-free mesh repair.
Absolutely. So after the surgical timeout, I'll make an oblique incision about 1 centimeter above and parallel to the inguinal ligament. I'll dissect down to the external oblique aponeurosis and open it along the line of its fibers to get into the inguinal canal. The very first critical structure I'm looking for is the ilioinguinal nerve. It has to be carefully identified and preserved. Once that's safe, I'll mobilize the spermatic cord and sling it with a Penrose drain. That gives me control and helps with retraction.
And this image here shows that anatomy perfectly. You can see where the external oblique has been opened up, exposing the whole inguinal canal. There's the spermatic cord, all mobilized. And right on top you can see the ilioinguinal nerve. Protecting that nerve, just like it's shown here, is without a doubt the single most important thing you can do to prevent chronic pain after the operation.
Let's introduce a complication. You open the hernia sac, and the bowel inside looks ischemic. It's non-viable. You have to resect it. This is now a contaminated field, so that prosthetic mesh is out of the question. How are you going to repair the hernia now?
In a contaminated field like that, after a bowel resection, using a prosthetic mesh is an absolute no-go. The risk of infection is just way too high, so I would immediately switch gears to a primary tissue repair. My two main options here would be either a Schultes repair, which is a really robust 4-layer reconstruction, or a Bazzini repair, where I'd suture the conjoined tendon to the inguinal ligament.
Correct. One last intraoperative question before we move on. The sliding hernia. You see the definition there. What's the key surgical implication? What does that really mean for you as a surgeon? The key implication is that you have to avoid injuring the organ, usually the colon or the bladder, that's actually making up part of the sac wall. It means you can't just open the sac carelessly. You have to dissect with extreme care and reduce the organ without incising that posterior wall of the sac. It's a critical safety step you have to get right before you can even think about closing the defect. Precisely. Okay, let's fast forward. The operation's done, the patient is back in your clinic 6 weeks later. He's telling you he has severe pain and numbness right around the surgical site, and the usual painkillers aren't touching it. How do you handle that?
My top concern here is chronic inguinal neuralgia, almost certainly from a nerve injury during the operation. The usual suspects are the ilioinguinal, the iliohypogastric, and the genital branch of the genitofemoral nerve. So, my first move is a very detailed physical exam to map out the sensory loss and try to find a trigger point that tells me which nerve is the culprit.
The management follows a very clear, stepwise plan. Step 1 is to start conservatively with things like anti-inflammatories and specific agents for neuropathic pain. If that doesn't work, Step 2 is a referral for a nerve block. This is great because it's both diagnostic and therapeutic. If the block works but wears off and the pain is still severe, then the final step is to consider surgical re-exploration. And that could mean anything from just freeing the nerve to removing the mesh, or in really tough cases, even performing a neurectomy.
Okay, time's up. That was a good performance overall. Now, this whole case really shines a light on some of the key things we look for in this exam. So let's just quickly summarize the main takeaways.
Look, to pass a station like this, you have to prove you're a safe, smart surgeon. Having a structured approach like you did is key. You absolutely must recognize the red flags for an emergency like strangulation and act on them fast. A rock-solid, detailed knowledge of inguinal anatomy is non-negotiable, and knowing both mesh and non-mesh repairs and exactly when to use them is essential. But you know what really makes a candidate stand out at the consultant level? It's being able to clearly lay out a plan for managing the tough complications after the surgery, like chronic pain. That's what we're really looking for.
So, as you move forward, always remember this. Prevention is infinitely better than treatment. The single most critical step in this entire procedure, the one that gives your patient the best chance at a great long-term outcome, is the one you mentioned early on. The meticulous, careful identification and preservation of those inguinal nerves right at the start of the operation. Never, ever forget that. The Viva is concluded.